Well, the question I'm supposed to answer in my presentation is, should response to a first-line agent guide the choice for a second-line treatment? And indeed, this is quite an interesting and clinically relevant question. But trying to clarify this kind of question a little bit further, we can also ask ourselves, does response or PFS benefit of a first-line treatment predict response or PFS benefit of a second-line treatment? Or to come to a very, very practical situation, after a first-line treatment, how to deal with these two different patient populations, those who did not achieve any benefit from a first-line treatment, or those who did achieve a benefit. Unfortunately enough, we have no prospective data to deal with, but we gathered many data from retrospective studies that could help us guiding in making this kind of decision. And particularly, we have the data gathered from the International MRCC Consortium that collected more than 450 patients treated with a first-line VEGF targeting agents and a second-line agent of the same class. These are the characteristics of these patients, typical characteristics from a typical patient population of advanced kidney cancer. Mainly patients received sunitinib in first line, but they also received sorafenib or bevacizumab. As a second-line treatment, they received mainly sorafenib, sunitinib again, and few cases did receive bevacizumab, pazopanib, or axitinib. All VEGF receptor targeting agents. Which was the clinical outcome to second-line treatment based on the response, clinical response to first-line? These are the results of a consortium clearly showing that which is observed first-line may be observed also in a second-line treatment. If we have some kind of benefit, either a response, an objective response, or at least a disease stabilization, well, probably these patients are going to respond also quite well to a second-line treatment. On the other hand, if the patients do not respond to a first-line treatment, we have not to expect any significant response in second-line. And as already Brian showed us, it is clear that there was no correlation between progression-free survival on first line and progression-free survival on second line. What does it mean in very practical terms? Well, it means that the choice of a second-line therapy should not be dependent on the response to a first-line treatment. Or if you want, that if there has been a poor outcome on a first-line VEGF targeting agent, then one should not necessarily avoid another agent of the same class as a second-line treatment. Or turn it around, if an excellent outcome on a first-line VEGF targeting agent has been observed, then it is unfortunately unknown how a second-line VEGF targeting agent will really perform in real life. This putative algorithm has been developed several years ago based on an original Temaisen idea. And at that time, it looked quite smart because we tried to make some suggestion according to the outcome of a first-line treatment. And particularly, it seems logical to propose to change class of drug in case of no answer at all to a first-line treatment, or else, in case of a long-term benefit before failure, it was realistically sound to propose to continue with a drug of the same class that achieved such a long-term benefit. Looks smart, I said, but no longer. No longer because we gather information about the so-called primary refractory patients, as well as on the long-term patients who benefited from a first-line treatment. Let's go to the issue of primary refractory patients. Once again, we can rely on the International MRCC Database Consortium, which analyzed the outcome of more than 1,000 patients and identified 26 of these 1,056 patients who had progression as their best response after a first-line treatment with a tyrosine kinase inhibitor. Unfortunately, only 40% of them did receive a second line, meaning that the natural history of this patient is extremely peculiar with a very dismally prognosis. But more interestingly, if we take a look at the treatment that these patients received after progression on first line, this is the progression-free outcome of a second-line treatment in terms of progression-free and overall survival. And as we can see, despite the idea that the primary refractory patients probably would need a completely different treatment, no differences were observed giving them second-line a TKI or an mTOR inhibitor. But as you can see, probably those who did receive another drug of the same class indeed seem to perform better than expected. We also gathered an European experience thanks to Laurence Elbige that collected data from French, Italian, UK centers. And we analyzed these patients trying to identify the outcome of primary refractory patients defined slightly differently from what have been done by the International MRCC Consortium. And indeed, we did not consider just those patients who had progression as their best response, but also consider those patients who initially started progressing without meeting RECIST criteria for progressive disease, and then at the second disease assessment, clearly matched the definition of progressing patients. And we analyzed the further treatments they received and, of course, the outcome of such treatments. Once again, no differences between a second-line TKI or a second-line mTOR inhibitor, neither in terms of overall survival or in terms of progression-free survival. No difference at all. And this observation clearly questions the idea of changing mechanism of action. That is a quite important things to think about, because we have to realize that at the end of the day, kidney cancer is extremely peculiar in that it heavily depends on angiogenesis. And since mTOR inhibitors do also act as anti-angiogenic treatments, as clearly demonstrated by several preclinical works, probably we are just talking about the possibility of targeting the same target just from different points. But the analysis that Laurence performed led also to a surprise that should be handled with great caution. And indeed, taking a look at the outcome of those patients who continued on sunitinib beyond progression, the progression-free survival of these patients was superimposable to the one of patients who immediately shifted to a second-line treatment. Meaning that patients in progression after 2 cycles of sunitinib showed a similar prognosis with a second-line treatment as those who continued on the same drug that determined disease progression. Let's move to long-term responders. Once again, we collected with Reza Eiladi and the group of Stefano D'Arta a large case series from different European centers. And we analyzed those patients who had a disease control for more than 6 or more than 11 months and the outcome of subsequent treatments, either another TKI or mTOR inhibitor. And here are the curves. Once again, no differences between a second-line tyrosine kinase inhibitor and an mTOR inhibitor. So, which kind of message to take home this night from this analysis? First, to answer the original question. We simply cannot rely on the response on a first-line treatment to predict the subsequent response to a second line. Second, the so-called primary refractory patients, irrespective of the definition we are going to use, are endowed by a very dismal prognosis, and no benefit is usually achieved in second line, irrespective of the drug used. And finally, long-term responders on a first-line TKI could benefit in second line from both another tyrosine kinase inhibitor as well as an mTOR inhibitor. No evidence presently favoring one sequence over the other. But one final consideration. Take these observations very cautiously, because they come mainly from retrospective series. Retrospective means also biased series, and therefore should be regarded as just exploratory and hypothesis generating. Thank you very much for your attention.